Hello friends, let us now learn some important questions. First, from previous year questions from AIMS, Northern blot is used for. Northern blot is used for RNA. So this blotting techniques is also important. I always remember it by the mnemonic SNOW, S for Southern blot and N for Northern, and there is no O, and W for Western blot. Okay, first we will have DNA in Watson and Crick model, then DNA gives RNA, RNA gives proteins. So Southern blot is for DNA, Northern blot is for RNA, and Western blot is for proteins. We have one more type which is called as Southwestern blot, which is for DNA binding proteins. It is recently being introduced. Southern Western blot, which is for DNA binding proteins. Then the next question, if you see, then biochemical biomarker of alcoholic hepatitis. Always remember, for alcohols biomarker is GGT. This for alcoholic hepatitis, gamma glutamyl transpeptidase is the biomedical marker. Actually, it is not specific for alcohol, but it is easily elevated in alcoholic liver disease and in fatty liver diseases. You will see that this GGT or gamma glutamyl transpeptidase is elevated. Okay, and then method of transport of glucose in intestine is, in intestine most of the glucose is transported by secondary active transport, that is by transport of glucose in intestine occurs in small intestine. It occurs by sodium glucose transporter, that is a secondary active transport, where sodium is transported. So for transport of sodium and glucose, ATP is required. For entry of glucose, ATP is required. I will just write this, draw this secondary active transport so that you become familiar with this. So this is the intestinal cell. Okay, in the intestinal cell, first glucose will enter the intestinal cell along with the sodium. It's sodium glucose symport. Okay, glucose and sodium, both these will enter. For the entry of sodium, this sodium will exit out. 3 sodium will exit out and 2 potassium will enter, and during this process ATP is utilized and it forms ADP and inorganic phosphate. So for glucose to enter, this sodium should go out and ATP should be utilized, because here the ATP is not directly utilized by this transporter, but there is a secondary transporter which is actually where the ATP is utilized. So this is called a secondary active transport. Right? Next, in non-competitive antagonism, which of the following is correct? In non-competitive antagonism, that means, what is non-competitive antagonism? This is a receptor, and to this receptor this will come and bind. Okay, we will think this is the thing which comes and binds. Now in non-competitive antagonism, there is a drug which is given, and this is actually inhibitor of this receptor, but it binds with some other site, and thus once it binds with other site, it causes conformational change in the in this receptor in such a way that now this protein which is there, it cannot bind to it. Okay, so this is non-competitive inhibitor, that is even without competing with this, it is inhibiting the enzyme. Okay, so for non-competitive inhibitor, if you see, if I draw the picture, so this is the V0 and this is the Km. So think that this is normal. Sorry, I'll draw it again. Think that this is normal. Now if you give a non-competitive inhibitor, now slowly the non-competitive inhibitor will start acting and it will inhibit the substrate binding to the enzyme, and as a result slowly the velocity of reaction decreases and decreases, and finally it is less than the normal reaction. So if you see, this is the Vmax. So here Vmax is decreased in non-competitive reaction, but Km is constant. Okay, that is what is seen in non-competitive reaction. If this is non-competitive, okay, but if you wanted to draw a similar graph to competitive reaction, so I will draw it in the similar, in this graph itself, but with different color. Okay, so if you see the competitive reaction, in competitive reaction, I'll draw in other no, in this graph only. See, in competitive reaction, slowly has the what is competitive reaction? Reversal of the reagent is possible. That is, for example, if this is the substrate, this is the enzyme, and this is the substrate. Now it has bound it. Now when the inhibitor comes, the inhibitor will this inhibitor, this is the inhibitor, this inhibitor will also be conformation, this inhibitor is also similar structurally, and as a result, now this inhibitor will compete with this substrate for the position of enzyme, and as a result, if the inhibitor wins, obviously it will inhibit the enzyme. So for the inhibitor to win, there should be concentration of inhibitor should be more than the substrate. But if you slowly increase the substrate concentration, then obviously inhibitor cannot act normally, right? So as you increase the substrate slowly, the maximum velocity can be reached here. So if I have to draw this graph, here it will be something like this. There is increase in the slowly you are increasing the concentration also. So when you increase the concentration, the graph becomes acute and it will reach the maximum velocity. So here if you see, Vmax is normal. Maximum velocity has been reached once you use maximum substrate, but the Km will Km will increase here. This is the Km due to this. Okay, Km will increase. That is the main difference between these. Okay, so here the question is about the non-competitive inhibitor. In non-competitive inhibitor, Vmax will decrease and Km is normal. So obviously this is Vmax will decrease. Okay, next question is, which of the following will occur normally in the body of a patient with type 1 diabetes mellitus having complaints of polyuria? If a person has type 1 diabetes mellitus and complaints of polyuria, what will happen? Okay, so whenever there is a patient with type 1 diabetes mellitus, first and foremost, I will tell you what will happen, and then we will come back to the question. If there is type 1 diabetes mellitus, first and foremost, there is decreased levels of insulin. This decreased levels of insulin will decrease the this decreased levels of insulin will decrease the fatty acid synthesis. Okay, so when the decreased insulin this causes decreased synthesis of fatty acids, and it will also increase the glucagon to increase. It increases the glucagon because insulin is decreased, so glucagon increases. That is, the conversion of glucose to glucagon increases, and glycogen, for that glucagon levels will increase. Okay, whenever there is decreased insulin, this will also cause decreased amount of acetyl CoA carboxylase activity will decrease. It will also decrease acetyl CoA carboxylase activity will decrease. Whenever there is decreased acetyl CoA carboxylase activity, then there is decreased malonyl CoA will decrease. So overall, there is one thing will happen, there is increased conversion of fatty acid to acetyl CoA will increase, and here there is also increased conversion of fatty acid to acetyl CoA will increase. So there is so if we will see the options. Glycogenesis in muscles. Actually, glycogenesis in muscles occur whenever there is increased insulin. So it does not occur in type 1 diabetes mellitus. Then increased protein synthesis. Actually insulin is necessary for protein synthesis. So this does not occur. Cholesterol, this is the answer, that it causes increased conversion of fatty acids to acetyl CoA. Thank you for watching.